Hi, my name's Kathy Harrison. I'm an advanced nurse practitioner at the Sheffield Haemophilia and Thrombosis Centre, which is a comprehensive care centre for bleeding disorders in the UK. I am the chair of the World Federation of Haemophilia Nurses Committee. I've worked in haemophilia and bleeding disorders care for about 18 years, have served on a number of working parties and groups historically during that time. I'm very passionate about the subject, and hopefully that will come through while we're talking today about this, this really useful and beneficial subject that I think needs to be talked about a little bit more. And just to give you a little bit more background about me, I am a mum of two, both rugby playing kiddywinks who are 13 and 11, and I'm a part-time first aider with the under-14s team that my son plays for, and enjoy arts and crafts and various bits and pieces when I'm not busy in the world of bleeding disorders. So on to the subject at hand, which is talking about prophylaxis in women with bleeding disorders, which is very limited in evidence, as we'll see as we go through, and hopefully you'll find some of the things I share today useful. Here are my disclosures. So I have worked with a number of the companies within bleeding disorders community to support and improve bleeding disorder care. Majority of the companies really in the last couple of years that I've worked with cover across the community. So really getting on to the subject at hand, what I think is important to recognise is that within healthcare and to a degree in society, women are invisible and have been for a long time. There's growing recognition that women are overlooked and underserved in terms of research and access to treatment options across the board in healthcare. Women were largely excluded from clinical trials until the 1990s, and the majority of the reason for that was because males were considered better test subjects, as they don't menstruate, have better hormone fluctuations, and cannot become pregnant. So I think that even at the grounding, we have reasons why perhaps we have less evidence for treatment decision making in our female population. The impact of that exclusion means that the biological differences between men and women are not identified within the research setting. So we have different risk factors for certain diseases, and women may respond differently to treatments as we use them. Excluding women from clinical trials means that efficacy and side effects in that population cannot be studied, and therefore some clinicians may be anxious or cautious about using recognised therapies in this patient group. And the lack of inclusivity in clinical trials and health studies means that there's more limited understanding of the health of female patients globally, really. But that exclusion from the study work, from research, from early access to products means that we see an increasing significance of inequities within medical research and in general health inequity. And whilst we might feel that things are getting better, it feels that that inequity is actually getting much wider. It can result in women receiving worse care, in a delayed diagnosis, which we'll reflect on as we go through the slides. And studies have found that gender bias in how clinicians view patients of different genders means that men are frequently seen as brave and stoic, whilst women are emotional or hysterical. So we can see that that gender bias, when dealing with things like chronic pain, can influence how a woman might be seen in the clinical setting. Sexism in healthcare is not new, but we are now recognising it more, and sexism in bleeding disorders as recognised and published here by Paula James and Angela Wayand, recognises the impact that sexism in bleeding disorders has on our affected women. The stigmatisation of menstruation, the normalisation of bleeding symptoms, it means that there is the risk of a long shadow over the evaluation of women with bleeding disorders. Sexism has been an issue in bleeding disorders for centuries, and it leads to an inequity for affected women. It means like things such as our normal ranges in our laboratories show that it's normal and okay to have an iron level in your boots. We know that that's not normal or okay, and women see a significant impact on their overall well-being because of that iron deficiency. But because the normal range in the laboratory identifies that that's what it should be, clinicians with inadequate information and knowledge about the subject think this is okay and leave women to struggle on with what could be symptomatic iron deficiency. Now, as I said, this is not a new issue. We were talking about this 25 years ago, and yet things don't seem to have improved. So certainly in the last 6 years, we looked at what should be the research priorities in the field of bleeding disorders, along with the Stop the Bleeding James Lind Alliance programme in the UK. And as part of that, there were a number of issues that highlighted about the importance of recognising women with bleeding disorders and prioritising their needs to be researched. So in the last 5 years, there has been some work that has occurred on evaluating this patient group. Here we can see Sarah Whitaker and colleagues' work from 2021 as reviewing women with bleeding disorders, and sorry, this is the Cinderella study, and from Kate Kerr and colleagues with women and bleeding disorders, women with ITP and women with haemophilia carriers. And we can see here that bleeding predominantly related to bruising or heavy periods or prolonged periods, which shouldn't be underestimated, the impact that prolonged menstrual bleeding has on women with bleeding disorders. But also perhaps more significant and well recognised in the male population, that of muscle bleeds, which are occurring, but perhaps we are not recognising the needs for prophylaxis and preventing this bleeding in our female group. Here we can see Sarah Whitaker's patient group, which focused on haemophilia carriers or women with haemophilia. And here we can see not only the well-recognised symptoms of easy bruising and heavy periods, but that again of joint bleeds that we would recognise if anybody was having a joint bleed with haemophilia, we'd be thinking about prophylaxis for that individual. So here we can also see from European data the recognition of women with bleeding disorders being delayed in diagnosis. From the from Kate Kerr's Cinderella study, we can see that we've had 5 out of 7 of these individuals who had a bleeding history but weren't diagnosed until after a child was born and was diagnosed with haemophilia. And even in families where we see a family history, whilst in this European data, we can see a significant difference in the median diagnosis in age 5 versus 19 years for those who were known versus unknown families with haemophilia. We can see that in other data that having a diagnosis of haemophilia in the family often makes women carriers who could be affected, with approximately 30% of female carriers having low reduced levels and having a bleeding phenotype, being overlooked when assessing who could be at risk of bleeding within that patient group, and still having bleeding symptoms but not being managed. Again, in the Cinderella study, we can see here the impact of poor communication on this patient group. The Cinderella study explored the lived experience of women and girls with bleeding disorders, and what really was identified was that there was very significant and poor communication with the patient group. Comments such as nobody ever talks to me, nobody's ever sat down with me and had that informed discussion about what are the real implications for this condition and the impact it might have on my life. The inconsistency of care, so always being seen by a different person and having to repeat the same story on repeat. I think being incredibly frustrating to anybody involved. But likewise, it was recognised the value of comprehensive care, the value of specialist provision and resource, that enough information and good communication from doctors and good psychological support was incredibly beneficial to those patients who reported. Many felt lucky or exceptionally lucky in the care provision they had been provided once they'd accessed specialist care, that staff went above and beyond to help the individual and their family, and that speaking to nurses in particular, felt that the patient was looked at as an individual and that the condition came secondary to that, which as a nurse myself is incredibly rewarding to recognise the impact that those little conversations have for these individuals. Because as we can see, amongst healthcare, normalisation of bleeding is significant. The number of women who'd been repeatedly to primary care and reported heavy menstrual bleeding, but had just been bounced away, saying it's nothing to worry about, it's just your period. That perhaps those in primary care who didn't recognise the possibility that a woman could have haemophilia, a woman could be affected by bleeding, again, telling them they don't need to worry about it, that it really enhances the things that we need to do to ensure our patient group can self-advocate when accessing different services. And I think we shouldn't underestimate the burden and trauma that individuals with bleeding disorders or women with bleeding disorders have undergone if they've had heavy menstrual bleeding throughout their teenage lives. The anxiety and depression associated with the embarrassment or trauma of having a leak whilst having heavy menstrual bleeding, the anxiety about attending school or work days when this type of event is happening, the anxiety and sadness about missing social events because they just either are too embarrassed to go or they're too exhausted because they're iron deficient anemic. In addition, many women who carry a condition who might or might not be affected may suffer from guilt associated with passing a gene on to a child. And that shouldn't be underestimated. And if we reflect on the delayed diagnosis that many women will have undergone before accessing care, or before accessing specialist care, the impact of those poor healthcare experiences has on them when they get to the point of being able to gain appropriate care provision. Yet, for decades, we've been talking about the principles of care for haemophilia being to ensure that patients have access to appropriate, resilient, and high-quality comprehensive care. So this is not new. These are the 2020 updated World Federation of Haemophilia guidelines for haemophilia, but this is not new principle of care. But we seem to be a long way behind when we think about women with bleeding disorders, despite this guideline really highlighting the importance of recognising women. Our healthcare provision is somewhere behind that. And some years ago, the the EHAD Women and Girls with Bleeding Disorders Working Party really hope to try and improve things, but with the development of the European Principles of Care for Women and Girls with Inherited Bleeding Disorders. With these 10 principles, the EHAD group really strived for equitable access and quality of care for all individuals with bleeding disorders, regardless of gender. They wanted to ensure that access to care for both female-specific and general bleeding symptoms. So we're not just talking about women having heavy menstrual bleeding, we're talking about women having other bleeding symptoms that we see in our male population. That they have access to the appropriate multidisciplinary care, treatments and counselling. And that we have timely and accurate diagnosis of bleeding disorders in women and girls. That we educate the public in looking out for signs of abnormal bleeding. That we have clear referral pathways into the specialist healthcare setting. That we have systematic approach to identification and testing of female carriers, and that they are then registered with haemophilia centres. The awareness of the additional challenges that are faced by women and girls with bleeding disorders throughout life, including the psychological support that is required, improved medical management, and more effective self-management and appropriate individualised treatment plans, including for surgery. And ensuring that comprehensive care is family-centred. Every patient contact is an opportunity to identify other affected family members or carriers, providing family-centred approach to education, and ensuring we have smooth transition for adolescents to adult services, but also for adults as they transition through different life journeys. That we should include dedicated obstetricians and gynecologists within our multidisciplinary teams. And that might include us having joint clinics where appropriate, but it should at least ensure that we have joint clinical guidelines and, again, individualised patient-centred care. Education of women and girls with bleeding disorders and their families regarding the menstrual cycle and its management. This could be age-appropriate and culturally sensitive written information or self-assessment and management, but should also entail menstrual plans prior to starting periods, strategies for prevention and immediate access to care for abnormal bleeding, and ensuring affected individuals understand how they can access provision. Early recognition and optimal management of heavy menstrual bleeding, provision of preconception counselling and access to prenatal diagnostics. We cannot do this without early diagnosis, with comprehensive and timely preconception counselling and reproductive choices discussed in a safe and non-judgmental way. And this can include genetic and prenatal diagnosis before pregnancy, not in a rushed way once somebody realises they are pregnant. And once pregnant, provision of patient-centred comprehensive management plan throughout pregnancy and the postpartum period, ensuring there is a clear birth plan in place well in advance of the delivery point, with access to appropriate clotting factors, knowledge of the clotting factor status and iron levels, and awareness of risk of bleeding at delivery and in that postpartum period. And finally, the involvement of women and girls with bleeding disorders in registries, clinical research and innovation. This should be uniform and internationally defined outcome measures, capturing of female-specific outcome measures in databases, sex-specific drug development, and active involvement in women in study design. So I think we can see that this is an absolute goal to be aiming towards when looking after our women with bleeding disorders. So to the subject at hand, now we've painted a rather bleak picture. Prophylaxis is defined as the administration of factor concentrate to prevent anticipated bleeding. In some individuals, short-term prophylaxis surrounding surgery, pregnancy or labour, and menstruation may be required to prevent or control excessive bleeding. While in individuals with severe bleeding phenotypes, Prophylaxis treatment is essential to prevent uncontrolled bleeding and reduce internal damage, such as joint damage, and prevent long-term sequelae. In patients with bleeding disorders, such as von Willebrand's disease, there is currently no consensus on the optimal use of prophylaxis or the associated cost-benefit of long-term prophylactic treatment. Yet in patients with severe haemophilia, prophylactic administration of clotting factor concentrates is the basis of modern treatment, and guidelines are widely accepted, whereas patients with von Willebrand's disease are typically treated on demand, and treatment guidelines for prophylaxis are less well characterised. Approximately 45% of patients with severe haemophilia A are thought to use some form of prophylaxis, compared with only 10% of patients with severe von Willebrand's disease. And while prophylaxis is used for patients with severe von Willebrand's disease, historically there's been less emphasis on the treatment of patients with mild to moderate disease, and the use of prophylaxis in type 1 and type 2 von Willebrand's disease is rare. Although the disease is very varied, studies have shown that patients with moderate haemophilia A report similar annualized bleeding rates to those with severe haemophilia A, suggesting there's a significant unmet treatment need in this patient group, and raises an interesting questions for individuals with less severe von Willebrand's disease and whether they're also relatively undertreated. Prophylaxis treatment in women is very underrepresented in the published evidence, perhaps in line with the poorly documented evidence for prophylaxis in conditions such as von Willebrand's disease. So I'm going to run through a few local cases now to show the impact of prophylaxis in a variety of inherited bleeding disorders in women with bleeding disorders in our local cohort. So we're starting with a couple of ladies who are both from Pakistani origin and both have severe factor 10 deficiency. They both have baseline factor 10 levels of 1%. Our first lady is a 48-year-old lady who has a significant bleeding history. She historically has had joint bleeds. She's had hemoperitoneum twice. So hemoperitoneum secondary to ruptured corpus luteum is a rare complication of women who are anticoagulated or those with certain bleeding disorders. In a local patient group, including severe factor 10, severe factor 7, and cytosterolemia, 5 of these episodes have been published, with 3 out of 5 being managed with blood products and factor concentrate. But 2 required surgical intervention and removal of the affected ovary. Suppression of ovulation via use of combined oral contraceptive pill can prevent further bleeds occurring, but renders the woman unable to have children during this time period. So we can see already the impact that having 2 of these types of bleeds for this individual would have had. Sadly, she did lose one of her ovaries and needed surgical intervention for one, but saved the other at the time of the bleed. She's had recurrent assault injuries due to domestic violence. She has had heavy menstrual bleeding lifelong. She's had muscle bleeds and iron deficiency anemia. So her treatment history, she's had on-demand prothrombin complex concentrate, or PCC. And at the age of 28, she was started on prophylaxis during her pregnancy. This was a much and longed for pregnancy. Following the completion of the pregnancy, she went back onto on-demand treatment. And then again, at the age of 35, she was sectioned under the Mental Health Act and again required prophylaxis. At this time, Coagidex, which is a pure factor 10 concentrate, was available as an early access scheme, and we were able to go into the psychiatric unit and treat her ourselves. So as the haemophilia nursing team went in to treat her. When she was discharged from there, Coagidex was no longer available, and on-demand, and she went back to on-demand treatment with PCC. She has very poor venous access, and the difference between a PCC versus Coagidex is quite significant in volume. But when Coagidex was finally made available in the UK, we were able to discuss with her about her giving prophylaxis. So she was started on the same dose she was given during her psychiatric treatment and had 20 to 25 units per kilo of Coagudex twice weekly at the age of 45, and she remains on that to this date. During that treatment, she has trough levels of 7% with a peak of 60%, and her bleeding pattern is significantly improved. And in the last 3 years since restarting prophylaxis, the main issues she's presented with have not been related to her factor 10 deficiency, but due to other general health issues rather than bleeding. In comparison, we can see our 22-year-old lady with, again, with severe factor 10 deficiency, who was diagnosed at the age of 4 weeks after presenting with umbilical stump bleeding and hematoma, and was immediately started on Coagudex prophylaxis because there was an open study available for her to go on. She's had no muscle or joint bleeds. She has had iron deficiency, which may be in part secondary to heavy menstrual bleeding. So she bleeds for 7 days, but days 1 to 3 are the heaviest. But she also reports not eating any vegetables. So it could also be dietary. But she has never needed IV iron and has managed with tolerating oral iron medication. She continued on Coagudex prophylaxis until the age of 14, where the study had finished in the UK, and the initial available access that was confirmed that would remain following the study was withdrawn after the UK did not build Coagudex onto the framework. It took 3 attempts of getting this product onto the framework, with much support from the clinicians within the UK and with the patient organisation, the Haemophilia Society. And at the age of 16, she was able to go back onto Coagudex prophylaxis every 3 days. And here we can see a trough of 14% and a peak of 55%. This young lady has dreadful venous access again, and her dad is actually a medic and does her administration. We certainly have spoken previously about her options going forward, as venous access is going to need to remain key for her having prophylaxis, and certainly in order for her to live independently as she ages, that's going to be a key priority for us moving forward. Next, looking at type 3 von Willebrand's disease. So our first lady was diagnosed at the age of 6 months. She's now 35 and has von Willebrand factor activity of less than 4%. She was known to have von Willebrand's disease in the family and inherited type 1 genes from both her parents. But mum had had VTE history, venous thrombosis, and had died in the intensive care unit secondary to sepsis. So there was some anxiety about overtreatment from the individual when she presented to us at the age of 29. She presented to us at the age of 29 because she moved her care here and had, as I say, been diagnosed at an early point and had access to care and treatment. She's a keen horse rider and wanted to become pregnant at the point where she met us at the age of 29. She'd had heavy menstrual bleeding since menarche. She had, on the day when I met her, when she arrived at the centre, she had extensive bruising. It was all over, very large bruises, all over her body. She suffered with extensive nosebleeds. She may have historically had some joint bleeds, but she has not had none since she's been with our practice. She's had iron deficiency anemia and has had muscle hematomas following trauma, usually related to falling off her horse. She's used tranexamic acid for periods without much improvement, has previously had secondary prophylaxis for a knee injury after falling off her horse, and she had that for a period of 18 months. She's intolerant of oral iron and needs IV iron top-ups every 4 to 6 months prior to starting prophylaxis. And she started prophylaxis at the point of seeing us in clinic, really coming with that as her thought that she did want prophylaxis. But she very quickly found the process overwhelming. She struggled with her mental health, initially managing twice weekly, but then tailing off very quickly. She then became pregnant at the age of 32 and had prophylaxis with Vonsento, 18 units per kilo. I will note that both of these individuals are well over 100 kilos. She had alternate daily treatment throughout the pregnancy and twice weekly thereafter. Her 24-hour activity levels, her von Willebrand activity levels, were 12%. So we can see that she does clear that very quickly. So at 48 hours, likely back to baseline. And at the point of her child being born, she did have Vayvondi, which is recombinant von Willebrand factor. So Vayvondi is not licensed for prophylaxis, so we were unable to give this to her for prophylaxis, but we could give it to her for managing the delivery and surgical episode. She went back onto Vonsento prophylaxis twice weekly since that point. This lady has had a significant input from psychosocial team members. She's had counselling, joint gynecology and obstetric clinic appointments, MDT bleeders clinic, which in our setting includes our consultant, a specialist nurse, our specialist physiotherapist, or social worker, sometimes our psychologist, and also sometimes our pharmacist. Our orthopedic clinic clinician saw her in conjunction with our haematologist and physiotherapist, and she's in close contact with the nursing team at all times. Second on our type 3s is a 53-year-old lady who has a von Willebrand activity or RCOF of less than 2%. And the reason they are slightly different is because of the way that they've been measured with different measuring agents or processes. So this lady has, we initially met in our service at the age of 31. She had been known to services before that. She was adopted, so does not know about her own personal family history or biological background. Heavy menstrual bleeding has dominated her life to the point of presentation with us at the age of 31, with increased difficulties in her late 20s. Upon meeting our consultant in the March, she reported the only 2 days that she'd been bleed-free were Christmas Day and Boxing Day of the previous year. By the time she reached us, she'd tried DDAVP, northisterone, the combined oral contraceptive pill, tranexamic acid, mefenamic acid, and Mirena coil, all without success. The Mirena coil fitting was attempted twice, but the heavy flow of blood loss washed both of them out, dropping her hemoglobin by 6 grams in a period of 3 weeks of bleeding. She struggled with poor venous access and suffered complications of a portacath after the line fractured. She had joint bleeds most of her life, and at the point of presentation was averaging 3 to 15 joint bleeds per year. She was at this point on demand with Hem8P, which was the older brother of Vonsento that we use now, using 30 units per kilo per event. And a trial of DDAVP was unsurprisingly revealed no response. She was on an antidepressant at the point of presentation, iron supplements, oral iron supplements, tranexamic acid, and mefenamic acid. She'd previously had allergic reactions to IV iron preparations, and a large number of individuals that have been involved in her care, from bleeding disorder MDT clinics, as I mentioned before, to vascular surgeons to have an AV fistula created in order to support her poor venous access improvement, orthopedic clinics, general surgeons, shared care with other services due to her residency outside of our direct region, primary care, gastroenterology, and the special care dentists. At the age of 34 in 2005, discussions started about prophylaxis. Highlighted that this wasn't routine practice in type 3 von Willebrand's disease at the time, but international trials were due to start with a view to establish if it would be helpful for joint bleeding in this group. Her AV fistula was created at the age of 36 under cover of hemate P, and subsequently she commenced on home delivery and prophylaxis, using approximately 30 units per kilo 3 times a week, with an additional 30 units per kilo for any breakthrough bleeds. In 2008, when she was 37 years old, there was a discussion about recombinant von Willebrand factor trial, but the study was never established locally or within reach for the patient. She increased her prophylaxis to 30 units per kilo, alternate daily, and that is what she is currently on. This lady, the only way that she could manage her heavy menstrual bleeding in the end was to have GnRH analog injections, so to switch off her periods completely. So we can see, how significant and burdensome the bleeding associated with both of these ladies' history was, and the importance of prophylaxis in supporting their care and reduction in bleeding. So what about type 2 von Willebrand's disease? We think about perhaps less severe, but activity levels still of 5 to 10%. So a type 2A, where we have a loss of the high molecular weight multimers, and type 2M, where they are restored. In the first lady, 58-year-old lady, so these are two similar age ladies, bleeding history of heavy menstrual bleeding, nosebleeds, GI bleeding starting at the age of 52 years, and angiodysplasia being diagnosed at the age of 54. She historically had initially been trialled with DDAVP, which reached a peak treatment level with a dizzy heights of 18%, which is not adequate for preventing bleeding or for surgery. She had tranexamic acid and a Mirena coil. Initially has been on demand, and in the main has managed with on-demand treatment for initially hemate P and now Voncento. However, when she was diagnosed with the angiodysplasia and experienced the GI bleeding, she had a period of time of 9 months where she was on Voncento, 25 units per kilo once weekly to manage that bleeding. She had APC and clipping of a large angioectasia and continued on prophylaxis for a period of 4 months after this to ensure healing had occurred, and then went back to on-demand Voncento. She still has treatment at home, so can self-treat if needed. So this was a skill that she learnt during the prophylaxis period, and certainly will be beneficial to her lifelong. And she may need to go back to prophylaxis in the future should she have any further difficulties with angiodysplasia. But certainly it certainly did the trick alongside the input from gastroenterology. Our other lady with 2M von Willebrand's, again 5% baseline levels, bleeding history, heavy menstrual bleeding, oral bleeding, which was so severe she was sat in a conference setting and had to leave the room because her mask filled with blood whilst in the post-COVID era. GI bleeding that started at the age of 47 years, nosebleeds, and severe widespread bruises. The treatment history, she's had tranexamic acid and on-demand hemate P or Voncento. At the age of 48, she had APC for AVM in a duodenum. During that time, she had tertiary prophylaxis in order to treat around this GI bleeding episode for 3 to 4 months, with Voncento at 25 units per kilo, once to twice weekly. And to manage her heavy menstrual bleeding, she actually had an endometrial ablation at the age of 40. And her oral bleeding has been significantly improved with really heavy input from our special care dentist, who performed 3-monthly scaling to improve her gum health, which has made huge differences to her as well. So whilst we recognise that prophylaxis is hugely important, very often it's performed in conjunction with other things to support prevention and reduction in bleeding. So the evidence certainly points towards prophylaxis in severes, but what about our less severe patient group? So in type 1 von Willebrand's disease, here we've got 2 ladies in their 20s. This first lady 23-year-old, von Willebrand factor activity of 30%. She's also got a platelet function disorder alongside her type 1 von Willebrand's disease. And she has a bleeding history of bruising, heavy menstrual bleeding, and nosebleeds. She had been treated in childhood with DDAVP on demand and tranexamic acid, and at the age of 18 was started on prophylaxis with Voncento, 20 units per kilo twice weekly for both her nosebleeds and for her heavy menstrual bleeding. At the age of 20, having had input from ENT, things had improved with her nosebleeds, and she therefore was able to drop her prophylaxis down to only treating twice in the week where she was on her menstrual period. And she, to this point, continues with this strategy for managing her periods. Another type 1 von Willebrand's lady with, again, similar levels, so activity 30 to 40%, now 29 years old, also has a platelet function disorder in addition to her von Willebrand's disease. She's now a qualified nurse, and she's had a really, really difficult ride over the last few years with significant heavy nosebleeds and heavy menstrual bleeding. There's been significant burden on her psychologically and physically from the amount of bleeding she has experienced, and she has had significant bruising as well. Initially, she was managed with tranexamic acid and DDAVP on demand. She had a contraceptive implant and Noraday to manage heavy menstrual bleeding, but this wasn't adequate, and tranexamic acid did little to benefit her. She was therefore started on DDAVP on days 1 and 3 of her menstrual period, and this has made things dramatically better with an improvement in her flow, so less heavy, although the period does still last for 7 days. And her nosebleeds have been dramatically improved with ENT input again, with artery ligation to improve things there. And finally, 2 ladies with platelet function disorders, so both in their early 30s. I think one of these is a clear example of the points earlier about delayed diagnosis. So she's a lady with storage pool disorder, a carrier of Bernard-Soulier disease. She was only diagnosed after her son was diagnosed with Bernard-Soulier, and she was referred up to us from the Children's Hospital. This is despite her having a significant bleeding history. So she's bled post-surgical, she's had post-surgical bleeding, post-dental extraction bleeding, extensive bruising, heavy menstrual bleeding since menopause, and she had a postpartum hemorrhage. Yet she wasn't picked up until her child was. Her most significant problems have been her heavy menstrual bleeding, and we manage all surgical episodes with DDAVP and tranexamic acid. But for her heavy menstrual bleeding, she now proactively treats on day 1 and 2, and this again has significantly improved the bleeding tendency and also reduced her iron deficiency. And similarly, another lady with storage pool disorder who had bleeding history of heavy menstrual bleeding, post-dental extraction bleeding, and prolonged bleeding after miscarriage. She historically used the on-demand DDAVP intranasal spray, which is currently not available, and has recently been taught how to self-inject. When I first met this lady a number of years ago, she was very needle phobic, and there is not a chance that she would have self-injected, but is now self-injecting, and she manages her heavy menstrual bleeding with not only being on the pill, but also using DDAVP on days 1, 2, and sometimes day 3 when needed. So I think we can see that that bleeding is having a huge impact on women with bleeding disorders of all different varieties. And from a recent paper from Wolfgang Maisbeck and Eric Berntorp, we can aiming to translate the evidence for success of prophylaxis in haemophilia to von Willebrand's disease. They shared this really nice graphic highlighting the benefits of prophylaxis in von Willebrand's disease. And I think this really highlights not just in von Willebrand's disease, but in all people, and particularly women with bleeding disorders. It reflects really nicely the points that we've made throughout the cases that I've discussed today, and adds to the need to work with women with inherited bleeding disorders to identify their goals in life and aims of treatment, so we can work together in a shared decision-making approach to ensure treatment and care provision meets the needs of the individual. That might include prophylaxis in some form, either long-term or specifically focused on events such as pregnancy or certain bleeding episodes. Times in the individual's life where risk is heightened, but with the aim to reduce bleeding risk and overall improve their quality of life. So in conclusion, we can see the evidence of prophylaxis in women with bleeding disorders is limited. Women with different bleeding disorders have varied bleeding presentations that may benefit from prophylaxis in primary, secondary or tertiary format. But access to timely diagnosis is key, and we need to listen to the impact of bleeding on individuals. Work to create an individualised care plan that meets their goals as well as ours. And we need to include more women in research studies. In a world where certainly in our own practice, supporting young men with severe haemophilia to be professional athletes and firefighters and achieve what historically seemed the impossible, surely we can strive to make our women bleed free and support them to be fully functional members of society without the burden of bleeding, disability and psychological harm. Thank you for listening. If you would like to get in touch with me, you can drop me an email or you can follow me on Twitter and message me through that. Thank you.